We'll be starting in 5 minutes. Please ask your colleagues or students to join as soon as possible. Bismillahirrahmanirrahim. Assalamu alaikum and a very warm welcome to all the participants. On behalf of PDA-Karachi chapter, I welcome you to the fourth session of our ongoing webinar series aimed at promoting clinical excellence and continued learning. Let's begin the session with the recitation of Holy Quran by Anas Sikandari, Dr. Anas from House Officer of Liaquat College of Medicine Dentistry.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفره إنه كان توابا صدق الله العظيم.
Jazakallah. Thank you for the beautiful recitation of Holy Quran. I am Dr. Rizwan Hassan and I'll be your host for today's webinar. It is my pleasure to introduce our esteemed speaker, Dr. Qureshi, BDS, MSc UK, and MDS from Pakistan, Associate Professor and Head of Department of Prosthodontics and Vice Principal at Fatma Jinnah Dental College. Today's topic is Mastering Canine Crown Preparation, a Clinical Roadmap, a subject of great importance for clinicians and students. Without further delay, I would now like to hand over the session to our respected speaker. Over to you, Dr. Samir.
Assalamu alaikum, everyone. I hope you all can hear me. Before we go on to starting the session, we begin with the name of Almighty Allah. We've already recited the verse from the Holy Quran, and I would like to praise Almighty Allah for giving us the opportunity to gather here and discuss some clinical tips, whatever I've been learning over the years, and whatever I've been taught. And I would like to thank PDA-Karachi, especially Professor Dr. Naveed Rashid Qureshi, my teacher, my mentor, and for giving us the opportunity, all dentists, to get together and through this webinar. And there's quite a good number here online, so it's a good thing to be sitting at home and sharing some clinical knowledge. If, however, you find me going fast or my pace or there's a lag in the internet, I've tried to keep two devices on. So you can always write in the chat box or raise your hand, whatever features are available there. And I hope I'm able to convey the message and begin with the recitation of the dua by Hazrat Musa alayhi salam, Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. So let me share the screen. Yes, my presentation starts here. Perfect. So I hope all of you can see my slide. Yes. I don't know if anyone is able to answer because it's on mute, but
Sir,
if
it's visible.
it's visible, great. So let us just pray that whatever we discuss today, it's not something to be memorized, it's something to be discussed, something to be gained knowledge from, and then incorporate this into our practices. And that's what beneficial knowledge is. Knowledge is not something we keep to ourselves. It's about sharing and then applying that knowledge. And it's also said that whatever knowledge you acquire, you'll be held accountable for that in some way or the other, in a negative way maybe. So I hope and pray that the message, my journey through whatever I've been taught and whatever I've been teaching over the past 24-ish years, I'm able to convey that and so on, right? So the topic of presentation, as you all know, is Mastering Canine Crown Preparation, a Clinical Roadmap. This would be not a theoretical discussion. I won't be talking about some theoretical aspects to what books which I'll be mentioning throughout is the Rosenstiel, the Contemporary of Fixed Prosthodontics, and the book by Schillenberg. So for reference, you can always go back and see those, and it's also available online. Canine teeth. Why did I choose canine tooth? When I was asked to give a presentation on this, canine, we know it's the cornerstone of our mouth. It plays a crucial role not only in aesthetics, but also guiding movements. When you talk about canine guided occlusion, it plays a pivotal role as well. And we have to understand that crown preparation for canines does, sorry, थोड़ा सा ये ऊपर आ गया names वाला. Let me minimize this. Yeah, perfect. So yes, so crown preparation, it remains one of the most sensitive technique procedures. If we keep on doing, you tend to realize that working teeth is difficult or relatively complex as compared to some other teeth. For example, if you tell me to prepare lower anterior, it will always be a nightmare because you cannot have those big margins, which I'll be discussing today, and keep the tooth's own and explore. Today we'll try and explore how to master each clinical step how to achieve precision detection and predictability. Please note that well-prepared tooth, or especially a canine tooth, which will be talked today, isn't just a matter of technique. It's a balance between art and science. So what you need to incorporate from the principles of crown preparation. I always repeat in my lectures that principles of crown preparations remain the same. You just to modify it according to that particular clinical scenario. But the principles in life, principles in dentistry should never. And similar principles do apply. For example, if you understand the principles of tooth preparation, the height, the width, the margins, the same principles apply to your implant dentistry. So coming back to canine tooth preparation, what we need to know, it demands respect for the anatomy, precision in reduction and understanding of function, which holds the key. Because if you're replacing a canine, if you're giving it a canine function, you need to know whether able to resist those lateral forces. This session is about mastering that balance, and I hope I'm able to convey my message. And I can repeat again, because it's online session. If you think I'm going fast, you can always request and or tell the admin so he can inform me as well. Starting within the theme cover, which I took from printed in Canadian, some of the Canadian journal. There was a conference in Ontario, no, Alberta, I guess, where we got this magazine. So the model on the cover magazine, what that she was selected as a model to take away from her face. So she's a beautiful lady, but when we talk about teeth, inadequate treatment planning, probably you can see the distinct difference between anterior and posterior. Maybe improper tooth preparation on the final aesthetic outcome. So as a dentist, we need to. There's some people in the chat. They want. Yes. Okay. So there's no harmony between anterior and posterior, and as clinicians, we need to plan, especially when working in the aesthetic zone. Following to that, with that. Patient's nightmare. This patient, which you're seeing right now on the screen, this lady is my patient, but in 4 years back, she came to me in late 80s. A very sweet lady came to me. She wanted crowns on her teeth to make her smile better. And my message for today would always, in each and every slide, until be please, if you ask me, I've given on the full mouth bridge work. And if you ask me personally, aapne kitne full mouth bridge work kiye, I can count on fingertips. That's what I tell my undergrad students as well, or my colleagues when we discuss. Is bound to go, towards the nightmarish. Look at this scenario. I said, your teeth. Tell her that she's in the late 80s, but obviously her teeth are fine till this age. One bridge. But she went to somewhere else and she was given this prosthesis, full mouth bridge work. And in 8 months, she came back to me. So if you see carefully, I started taking out crowns, bridges. First, 2 sittings I spent on her, counseling her. She's a nice lady, lives in the United States, comes here every 6 months. So, but I was shattered because ये हमारी वालदा की age की मैंने बोला इन्होंने क्यों जुल्म किया, and even whatever you compromise scenario, and if you see carefully, only I've taken out all teeth and replaced them, but if you see carefully, if you can see my mouse moving, the basic principles of crown flip have been, I've been messaged that मेरी आवाज अटक के आ रही है. Is that true? मतलब सबको आ रही है नहीं आ रही है? I'm sorry if voice
Yes,
isn't clear.
आपकी voice थोड़ी clear नहीं हो रही है. Internet connectivity issue आ रहा है, I think.
इंटरनेट कनेक्टिविटी इशू आ रहा है. मैं इसको और बेहतर हूँ. ऐसे तो 5G जो भी है कनेक्शन वो हुआ है भाई.
So now it's clear.
So whenever the admin, I will request when my voice isn't clear, please stop me because it's online. अगर message clear नहीं हो रहा तो it's loss of the discussion here. So coming back to the slide, the basic principles over her mouth were bypassed. If I go back and show you her anterior front teeth, you can see um, these two were contics, but canines overhang crowns, hang crowns. Why do we get overhang crowns? Always remember the dentist to be blamed. It's very easy to blame the technician. Yes, this technician isn't great. जिस तरह का उन्होंने fridge bridge किया, horrible work, horrible work. But we need to prepare at such a fashion, in such a principled way that the lab has, space to work around those aesthetic areas. I'll move on and show you those as well, the principles. Excuse me. Eventually, a full mouth bridge work was again given and done. We moved from this scenario to this scenario. It's been 2 years. It's been 2 years that she's got this no gingival inflammation yet. Perio maintenance is there. The case was eventually completed with rather successfully with well-fitting crowns. As you can compare, the patient was fully satisfied of the outcomes, and visually. Yes, you can say the longer, but her had a low lip line and much couldn't be done because she was here for only a month. No tissue grafting could have been carried out to bring that gingival structure down. So always remember, what we give to the lab is what we get, and your lab selection should be is important as well, because if you remember, the saying goes, if you pay peanuts, you get monkeys. So yes, cheaper labs or cheaper crown preparation or principles would give you a cheap options. Cheap would be taken both ways. कि आपका प्रोसीजर भी बड़ा cheap किया है और आपने हमने मैंने आपने the outcome was also very compromised. So restoration selection, I won't go in detail into selecting which restorations, but when we do restoration, we have to keep what restoration we are following. Whether I'm going for the conventional to metal, whether I'm going for zirconias, or when I say ceramic, it means lithium disilicates. Although zirconia is also a metal, but we consider it as all ceramic. But here the mention of all ceramic is related to lithium disilicates. So which restoration you're going for is very important for you to decide. That is all dependent on the patient's pocket. But as you can see, the difference between disilicate and zirconia and PFM. PFM is more opaque, more duller. So my recommendation always would be that working in the aesthetic zone, if the patient has a high smile line, her the pink and white aesthetic is visible, and always try to go for makes life easier for multiple reasons as we move on. And when we talk about zirconiums and lithium disilicates are more life, more vibrant as compared to are opaque. Layered zirconiums also available. What is lagging, I've been told. Everyone facing that, please, if others can also, some of you are with me on WhatsApp, can let me know. Dr. Abbas, please. I've got the device next to me, so I'm sorry अगर आपको ये lagging थोड़ी लग रही है. मैं इसको solve हूँ, just bear with me, please. Okay. So I've tried and changed the net, so I hope it's not lagging as much. Please let me know if you feel it's lagging, then I can always. Right. So, can you hear me now? Yes, it's fine. Great. I'm really sorry about that. Internet issues. I've got the 5G, 4G all with me right now, but I don't know. So anyway, so moving on, selection of prosthesis and your preparation will always be dependent on the type of restorations you're opting for. Because that preparation holds the key. Because if you can see on the present slide, fracturing, this is a very common occurrence, especially in the aesthetic zone where the teeth are smaller or the occlusal load is more. Which restoration? If we talk about metal-free restorations, you can see here that cracking up is the main issue. And this, yes, could be associated with the occlusal load. So you need to manage. But if you see this patient's occlusion, it's not a bruxis. This patient isn't a bruxis. However, this in research and papers has also been associated with irregular crown preparations. When we talk about preparation for metal-free restorations, these preparations are technique sensitive. These restorations, sorry, are technique sensitive. They cannot withstand irregular prep. Irregular preps causes internal cracks when on biting, and that eventually causes fracturing of the prosthesis. So your preparation should be smooth, which we'll talk about as we move on further. So coming back to the preparations, principles of tooth preparation, we've studied in our undergrad days, and this is from Rosenstiel, the contemporary of fixed prosthodontics, where we have biologic principles, mechanical and aesthetic, and the optimal will always be there when we combine all three principles together. Our basic principle from day one has been we need to conserve tooth structure. Unnecessary reduction of tooth isn't required. And for that, always remember, आपके अंदर एक मुफ्ती बैठा है. अगर preparation के बाद canine के shape में नहीं लग रहा, that means there's something wrong with your preparation. If your central isn't looking like a central incisor, you'll always get to know that it isn't a great prep. And your molar should look like a molar. ये नहीं हो premolar हो जाए, canine central incisor ये lower की तरह लगने लगे. So that is one important point to know and ask yourself whether, excuse me, this preparation is good enough or not. Over contouring, we'll talk a bit about that. Margin placement is the key. We'll talk a bit about that. Occlusion, another topic to be discussed, and future damage from preparation while preparing the adjacent teeth. A bit of retention resistance form will also be discussed. Aesthetics. So aesthetic, obviously, it depends on your preparation. It doesn't depend on the lab. It depends on the material you select. And on top of that, what preparation am I giving my lab, which will aid in a well-contoured preparation. So life of a crown. How does the crown stay in the mouth? Three basic features हैं. Along with that, there are multiple others, but three basic principles हैं. The taper of a restoration, the diameter, and the height of the preparation. For this, Schellenberg says you need to, in order to maintain the diameter, you need to do anatomical preparation. You need to have an anatomical preparation. If you do a proper anatomical preparation, you will eventually have a better height and lesser taper. If you see in this image here, this central incisor doesn't look like a central incisor. It's already been, over reduced, over prepared. So it's automatic, it's obvious. The patient will keep on coming back with the complaint of crown getting dislodged because there's no margin visible, and the height and the taper is a lot. So loss of anatomical form would lead to what? Loss of anatomical form would lead to over taper of the tooth. Tapering, the convergence increase ho jayegi. Loss of tooth structure. Loss of tooth structure in vital teeth would eventually lead to pulpal exposure or requirement of a root canal. And as I just mentioned, pulpal damage. and loss of eventually retention and resistance of a tooth, the crown. So if the patient keeps on coming back with the complaint of crown getting dislodged, always remember it's associated with more to do with your over preparation of the tooth. Am I going fine? Please let me know. Again, it's online, so we need to ask again and again.
It's going fine and you are audible, sir. Thank you.
Great, great. And there's a message as well. Perfect. Thank you. So taper. Taper is the most essential factor in which a crown preparation is decided whether it's good or bad. Taper is the criteria with which you judge in international exams to pass or fail a student, the dimensions of a crown prep and the taper. Okay, the more the taper, the less the retention. Yeah, taper is what? Taper is basically the convergence of two opposing walls, whether it's mesial distal, buccal lingual. And ideally, you would need parallel walls, but more parallel walls would create undercut, which I'll show you the image as we move on. But lesser taper would always aid in better path of insertion removal. It will help in removing removing the undercuts and permit more nearly complete seating of the restoration. Ideal taper, they say 6 degrees. अब ये सारी बुकिश बातें होती हैं, हम किस तरह मेजर करेंगे? रोजनस्टीन ने बुक में बताया 12:01 हो, एज दे से 1:12. तो 12 और 1 के बीच में जो एंगल बन रहा है, दैट इज योर आइडियल टेपर. बट एज आई मूव ऑन, आई विल शो यू द बर यूज और उसकी टेपर कैसे करना है. शिलेनबर्ग ने दिखाया द मोर द टेपर द लेस द रिटेंशन. तो डिग्री ऑफ टेपर एज इज इंक्रीजेस 45 डिग्रीज 50 तक जा रहा है, तो रिटेंशन भी कॉम्प्रोमाइज हो रही है. बट जितना टेपर लेस है उतनी रिटेंशन बेहतर हो रही है. And this image would help us in visualizing this. The 5 degrees taper would look like this. As we move on, it becomes cone shape. So jitna angle kam hota jayega, eventually you'll keep on losing the tooth structure. You could keep on losing the anatomy as well, as is visible on this image. This is 10 to 12 degrees taper. Ye bhi kitna kam lag raha hai, but there is 10 degrees. It's not a failure, but the naked eye से जो visible होता है वो काफी ज्यादा bypass कर जाता है. Holding, Schillenberg ने बताया कि holding of your instrument. In this image over here, these three images, this image is the perfect holding because of positioning of the burr, because this burr is already tapered. So the use of your cutting instrument and the type of cutting instrument is also very important. What kind of an instrument you're using? Or if it's parallel, then you might tilt it. But for young practitioners, my advice is always hold it 90 degrees. Undercut can always be corrected. And with scanners, तो आप उसी वक्त उसको स्कैन करके हम अंडरकट उसी वक्त देख लेते हैं. बट इम्प्रेशन में भी आप लैब बोल सकती है कि वापस लो. बट इफ हाउएवर यू रिड्यूस मोर, कि आपका पहले ही टेपर्ड बार है और आप उसके हैंडपीस को भी टिल्ट कर रहे हैं टेपर प्रोड्यूस करने के लिए, देन इवेंचुअली टेपर इंक्रीज होता जाएगा. एंड इफ यू होल्ड इट इन दिस वे, तो इसमें अंडरकट प्रोड्यूस होंगे. एंड इफ यू होल्ड इट दिस वे, अ टेपर्ड बार, इट विल keep on increasing the convergence and eventually increase the taper of the crown and less the retention eventually. So इसमें भी देखें less taper है, इसमें there's more taper, this is less taper, but there's a bit of undercut here. You do not want undercut in your preparation. Why the undercuts? What they do is the lab fills up these undercuts, and then the gap between the internal surface of the crown and the cement increases. And once that increases, it can in the future cause leakage or fracturing of the cement, because the cement under stress fractures. That's the property, that's how it works. So moving from the taper, axial reduction. This is on the basis of axial reduction, good anatomical contours are decided, whether it's overhang or not. On the basis of this anatomical reduction is decided whether your emergence profile is straight, convex, or concave. Because a tooth preparation should be such that the junction between the restoration and the tooth be smooth. This also, your margin helps in the type of margin you select in. Also select is also helps in forming the axial contours. Because if you see cases over the years, there's a distant, and if you see in your patients, I've seen in few of my patients as well, और your relatives जिनको multiple crown bridge लगे हैं, आपको एक red cherry bands नजर आ रहे होंगे, and those are more to do with the crowns we give, and especially the placement of the margins. So therefore, axial contours, axial reduction holds the key. We'll talk about that when जब हम clinical step करेंगे and clinical demo देंगे. Cutting instrument, the type of cutting instrument you're using, the electron microscopic view taken from Rosenstiel tells us this first image is of unused diamond and used diamond. So on the used diamond, you can see a lot of debris on the burr. Unused diamond is like a brand new knife, which easily cuts through without damaging. And especially if you're doing prep on your non-vital teeth, it produces more friction, more heat. And the second part, you can see unused tungsten carbide compared to used fractured tungsten carbide. If you use such burrs on the teeth, what happens? More heat is generated and more friction damages our handpiece. So the more newer the burr, the better the prep. That is the basic principle told us. But after taper, the most essential aspect of crown preparation is the margin. Margin is the area from where the issues occur. Margin leakage, marginal caries, marginal gingivitis, you name it, and the list goes on. And this is all in our hands. हम किस तरह की margin prepare करते हैं? Always remember that it's always easy to prepare the margin the first time. Once you go inside the dentine, for example, someone has already prepared, over prepared the tooth. अब उसमें जब second time आपको margin बनाने होगी, it will be a nightmare. Easy नहीं होता. Then you need to compromise according to the tooth structure कि उसको lesser prepare करें और कौन सी margin दें. But that is not my topic to discuss. My topic is talking about the margin selection. For all ceramic restorations, aesthetic restoration, the margin could be a deep chamfer or a shoulder 90-degree cavo surface angle. The most famous of the two crown margin preparation. Chamfer, as we know, is a gingival finish line which forms an obtuse angle with the axial wall. Sloping margin hoti hai. It's ideally suitable for metal or margin या metal ceramic की जो metal margin है उसके लिए. However, if you make the chamfer deeper with a thicker chamfer burr, what you'll achieve is a rounded cavo surface angle. Deep shoulder भी कहते हैं, rounded shoulder भी कहते हैं, and deep chamfer भी कहते हैं. This is a distant margin which can easily be identified and can easily be used. I'll show you, we'll be making rounded shoulder in the clinical step as well. And this is how a chamfer margin looks like. Always remember, the thickness of the margin, for example, if it says 1 mm is required, your burr's diameter is very important in selecting. Always measure the diameter of your burr and then take that amount of diameter. We'll show you while preparing on the clinical steps, जो आपको slides में दिखाएंगे कि depth orientation grooves का इसमें बड़ा role है. That is what helps us in determining the amount of reduction and the amount of margin depth we've achieved. Why is that important? I'll show you as we move on. Shoulder margin, the least conservative, the most aesthetic margin, because it accommodates a lot of material. It accommodates a lot of material and it is very essential for your aesthetic restoration. Preferred for biologic and aesthetic reason, provides adequate space of the material, and that is the function of a margin. My favorite सवाल is कि margin का क्या role है? Margin has nothing to do with retention. Margin helps in seating of the prosthesis, helps in maintaining the gingival health, helps in providing seal. एक seating के लिए है. Retention, taking the crown out, margin will never stop it. It's the taper, it's the height, it's the diameter which helps the crown in sticking in. Margin का सिर्फ role है seating के लिए. Like I'm sitting on the seat, ये मुझे seat provide कर रही है. मैं उठूंगा, ये मुझे रोक नहीं सकेगी. So it depends if you're doing all ceramic restoration तो आपको पूरा all around देना है. Metal ceramic देते हैं तो buccal surface पे shoulder देंगे, rest पे you go on and give your metal chamfer या shoulder भी दे सकते हैं. So this is what a rounded cavo surface. Butt joint क्यों preferred नहीं होता? As we move on, I'll show you an image. वो butt joint two flat surfaces बनाती हैं जहाँ cracks आते हैं. वो आगे जाके आएगा तो we'll see that. So preferred a rounded exogingival line angle or a flat one is recommended, but I would say a rounded cavo surface angle or a deep chamfer is pretty good. उसमें cracks भी नहीं होते और उसमें fracture के chances भी नहीं होते. So this is how much a 1.1 or a 1.4 margin, shoulder margin looks like. But always remember when preparing, I would also stop here and point out that if you have any questions, you can write down in your chat box. तो वो end पे moderator आप ले लेंगे and we can discuss those. जहाँ भी slide पे आपको लगे कोई सवाल है या कुछ पूछना है. So I'm audible without any lag. Please let me know.
Yes, sir, you are audible.
Perfect.
Question answers
So
will take in the end.
जी. So, but one of the most, when you're making a shoulder margin, this is the most common error, the gutter formation. ये जो gutter formation है, what it does is ये जो arrow दिखा रहा है, ये unsupported enamel बनते हैं. Why it happens? When we are, what do you call it, preparing a margin, my belief is, and my teaching is always, never try to make a margin. Margin will be formed itself once you reduce the tooth axially. आप बकल कर रहे हैं, लिंगुअल कर रहे हैं, जिस वक्त आप मार्जिन बनाने लगेंगे ना, आप या तो इस तरह गटर फॉर्मेशन करेंगे या अंडरकट फॉर्मेशन हो जाएगी या इरेगुलर मार्जिन हो. इफ यू मूव योर बर स्मूथली like from one surface to the other, वो खुद ही खुद मार्जिन बनती जाएगी, वो बर के पॉजिटिव को नेगेटिव में ट्रांसफर कर देगी, नेगेटिव को पॉजिटिव में, सॉरी, or the other way around. So, but this happens very commonly, and this unsupported structure fractures eventually. ये unsupported enamel है, ये जो tip नजर आ रही है, I hope you can see it, and this would eventually fracture, and that is where your open margin starts, and that is where the caries under the crown takes place. Schillenberg says if you give irregular margins for all ceramic restoration, there are more likely chances of the prosthesis fracturing. That is why these restorations are not forgiving. These preparations, the preparation for all ceramic, and especially in the anterior aesthetic zone or the canine, you need to have a smooth margins in order to the prosthesis to not to have internal cracks or fracture. This is very important point to remember. Then placement of the margin. Always remember, avoid unnecessary apical extension. Why? You all know that. Anyone can point out? Anyone can mention in the chat box. I'd love to get answers from you all. Because whenever possible, it's basically, sorry, इसको बंद कर दें. Yes, not only gingivitis, but inflammation of the gums, but इसका better word है violation of the biologic fit. Because block, and a lot of periodontists say never try to go inside the margin. Keep your margins supragingival, always. और aesthetic restorations या metal free का यही फायदा है, आप equigingival भी रख सकते हैं. Subgingival, if you have to go subgingival, then only 0.5 millimeter, not beyond that. Because the further you go, the more chances of biologic width. अब वो periodontally topic चले जाएगा, तो मैं biologic width नहीं discuss कर रहा. Basically, it's a band of healthy junctional epithelium and connective tissue which is present all around the tooth. 360 degree पे present होता है, which protect. The closer you go to the biologic width, the more it starts receding, और फिर gingival inflammation भी होती है. So please never go subgingival. And sometimes you need to go, फिर आप biologic width measure करें और जाएं तो सिर्फ 0.5 mm जाएं. Always keep it supragingival. Subgingival you don't need to go. So coming to the clinical steps, we need to know the dimensions. Either incisally mentioned है 2 mm. This is the maximum limit. The more you reduce incisally, what are you doing? The thickness of porcelain is increasing. Once the thickness of the porcelain increases, it's bound to fracture. Ceramics, zirconiums, whatever, उनकी जितना आप thickness बढ़ाएंगे, इतना brittle होता जाएगा, उतना it's bound to fracture. एंड शोल्डर मार्जिन 1 to K9 है तो मैं 1.2 तक भी जा सकते हैं, बहुत चौड़ा है तो 1.5 से भी, लेकिन अगर लैटरल है तो 1 mm तक. So these are the dimensions required for your interior preparation, K9 preparation. But before we pick up a handpiece and start going on to the clinical side, key tooth preparation form and decisions. Finish line. You need to know what finish line you're going to prepare. Deep chamfer, shoulder, whatever you're doing, you need to prefer. You don't just pick up your bar, whatever you get in hand, and keep on reducing it. उससे irregular margin होती है, उनसे उससे indecisiveness से outcome नहीं होता. So जैसे there's a famous saying, you begin with the end in mind. कि आपको foresee करना है कि मेरी preparation, जब ये खाका बना लेंगे, believe me, आपकी preparation खुद अच्छी होती जाएगी. That is what, अगर blueprint है तो subconsciously आपका muscle memory भी उसी तरह चलेगी. Convergence, taper को control करना, वो किस तरह है वो उसको आगे जाके देखेंगे. And the amount and form of reduction, obviously this is dependent on the type of crown restoration. PFM के लिए अलग होगा, metal zirconium के लिए, and lithium disilicate के लिए अलग होगा. And if it's already reduced more, then whether you need to give any anti-rotational grooves, if the degree of taper has increased, or the occlusal gingival height has increased, yeah, crown lengthening karni hai. So that needs to be determined prior to your picking up your handpiece and preparing the tooth. These are some of the burrs used. The interdental burr, chamfer burr if you're giving a chamfer margin, short taper for incisor reduction, shoulder burr, and the flame shaped burr. Or the one burr which I use very commonly is the TR13C. इससे मेरा rounded shoulder भी बन जाता है and deep chamfer भी बन जाता है, जो rounded के वो surface आएंगे, इससे बड़ा खूबसूरत बनता है. TR13C is the burr, name of the burr. These two burrs are the one, the shoulder, और ये मैं commonly use करता हूँ and recommend करता हूँ. ये बहुत पतला burr है, needle burr. इसमें पतला नजर नहीं आ रहा, लेकिन it's quite a thin burr. So uh, tooth preparation. Sorry. Tooth preparation के कुछ features हैं, कुछ principles हैं, कुछ steps हैं which we need to know. We need to incorporate in our. We start with the incisal reduction. We move on from the incisal reduction to the labial aspect. Then take the labial aspect. We will do that clinically. मैं clinical pictures भी show करूँगा, फिर आपको video भी show करूँगा before we end the lecture. Then from the labial aspect, planar reduction, from the planes, you move on to the interproximal side and then the lingual side. Some say when you're doing a preparation, always look closely at the tooth before preparation. कि जिस दांत को करना है, whether it's endodontically restored, whether it's half of tooth is with the filling or whatever, you need to know the tooth before the area you're working in. And then plan accordingly कि मैं इसकी margin कहाँ place करूँगा, इसकी incisal reduction किस तरह होगी, वो जैसे as I said, the blueprint, the खाका, and then you move on. So you see the occlusal clearance, whether how much is required or not, the occlusal relation of that particular tooth with the opposing teeth, and then you plan. This is how you plan your this is how, for example, if you central or canine में यही फर्क है. Canine is reduced in this way, and you can decide आप आगे से पीछे जाना है, पीछे से आगे, but your movement should be in one direction of the burr. We'll talk about that as we move on. You start with the depth orientation groove, which is the incisal reduction. The first thing you do is give two, on the slopes, give two depth orientation groove. What is the function of depth orientation groove? अंग्रेजी का word है depth orientation groove. It orients us, let us know कि कितनी depth में, उस bar का diameter के accordingly मैं depth दूंगा. I need to reduce 1 mm. Phantom teeth या initial, I would recommend कि आप कम prepare करें ताकि बाद में you have something to play around. पहले ही ज्यादा कर देंगे तो वो फिर eventually issue create करेगा. So you give depth orientation grooves, which are given in this fashion, as you can see in the image here. Now the joining, excuse me. The joining of the depth orientation groove is crucial, is critical. As you can see, these grooves, जिसको हम depth orientation groove बोल रहे हैं, ये तो depth बन गई है, ये depth नहीं है. So these islands next to the groove, they have to be joined to this area. They have to be joined to this area. So the idea should be कि don't reduce the already reduced groove. but reduce these two areas, one, two, and three areas. Then you'll get to know कि मेरी ये 1.2 reduction जितनी भी bar की depth है उतनी achieve हुई है या नहीं हुई है. And try and move. देखिए, a smooth crown preparation हम हमेशा बोलते हैं smooth होनी चाहिए, smooth का एक ही principle है, movement of your cutting instrument. एक तो new cutting instrument and how you move it. आगे पीछे घिसेंगे वो रेगमाल वाला इफेक्ट आ जाएगा साउंड पेपर. That is what you don't want. But move in one direction, leave it, come back and then move it. तो वो स्मूथ होगा. It's slicing like you slice an onion. इतना खूबसूरती से कटता है ये क्यूकम्बर, वो पतले पतले स्लाइसेस. तो मुझे नहीं आता, लेकिन मैंने ऐसे देखा है वीडियोस में. So this is, once you achieve that, you know the amount of reduction achieved is enough for my occlusal clearance. Don't keep on going more, because occlusogingival height is also very critical for retention. Always remember. On the basis of this height, you decide whether to take your margin subgingival or not. मैंने ये शुरू में sorry mention नहीं किया. मैं वापस पूछूंगा, मैं तेज तो नहीं जा रहा. Please मुझे message पे इधर बता दें. So yes, coming back to the topic, placement of the subgingival margin is always dependent on the smile line of the patient, whether I need to take the margin subgingivally, then whether there's cervical caries, or one of the many aspect is whether the occlusogingival height is less. To gain retention, I need to go subgingival. तो मेरी पहले ही प्रिंसिपल है, कुछ ऑपरेटर्स बोलते हैं आप पहले मार्जिन बनाएं फिर ओक्लूजल रिडक्शन करें, बट माय थ्योरी एंड माय रैशनल इज, और माय फॉलोइंग फ्रॉम माय मेंटोर इज, कि पहले आप इंसाइजरी करें, देन देखें आपका कितना स्ट्रक्चर है. ऑन द बेसिस ऑफ दैट, देन यू डिसाइड वेदर आई शुड गो सबजिंजिवल और नॉट. व्हाई? मार्जिन हमेशा एक दफा बनती है. इफ यू मेक ट्वाइस और थ्राइस, फॉर एग्जांपल पहले आपने इक्विजिंजिवल मार्जिन दे दी, ठीक है ना, और उसके बाद आप बोलेंगे अब सबजिंजिवल एक और देंगे, फिर आप दूसरा रिड्यूस कर, यू कीप ऑन रिड्यूसिंग मोर, उससे आपका ये डिस्ट्रक्शन ही होती है, उससे आपकी डिस्ट्रक्शन ही होती है, एंड और कुछ अचीव नहीं होता. ठीक है, सॉरी ये थोड़ा सा रिड्यूस कर दूं मैं. Okay, yes. So once we get the clearance, we know we've got enough clearance of 1.5, then we move on to the labial reduction. Now this is where the anatomical forms comes in. Always remember, it's planar reduction. मैं आगे जाके उसकी इमेज भी दिखाऊंगा. Planar reduction. शिलेनबर्ग ने बुक में दिया हुआ प्लेन्स में रिड्यूस करना है, स्पेशली द एंटीरियर टीथ. ये प्लेन नजर आ रहा है और आपको दूसरा प्लेन आ रहा है. सो दिस इज फ्रॉम सर्वाइकल टू द मिड, and then from the mid to the incisor. And this is all dependent on your cutting. अगर मैं अपनी कटिंग में बर को बिल्कुल स्ट्रेट रखूंगा जो आगे जाके आएगा, then ये पूरा फ्लैटर हो जाएगा. फ्लैट हो जाएगा, उससे I lose the anatomy. फ्लैट हो जाएगा, I'm losing the anatomy. Along with that, what I'm doing is I'm going inside the pulp. I'm losing the tooth structure. Therefore, angulation and holding your handpiece is also very important. This particularly forms a 45-degree angle, somewhat like that. If you get confused, always practice outside the mouth so that you know these principles. And then आप depth orientation group दे दें, आप half depth लें depending on the width of the burr you're using. And then second part is cervical prep, straight cervically. आप देख रहे थे पहले का angle 45 था, ये बिल्कुल parallel along the long axis of the tooth. Eventually, by doing this, what are we achieving? ये तकरीबन 90-degree angle पे इस तरह बार रखा है cervical prep के लिए. By doing this, once you join this, you get, ये तो grooves दिखाएं. You try and move your burr in one direction, as mentioned earlier, from back and forth नहीं करना है. And इसमें देखें आपका पहले से shape बन रहा है. ये mid to incisal and then mid to cervical. Sorry, ये पीछे चले गए. And then you can see occlusally as well, incisally as well. Now this is the contour I was mentioning. This was what I was mentioning. Moving in the burr in one direction, back and forth nahi karna, and the anatomy is being followed as well. बड़ा important है. इसको further मैं आगे जाके दिखाता हूँ, आपको ऐसा ना लगे मैं जल्दी से गुजर रहा हूँ. But you can see a rounded cavo surface angle being formed. Margin नहीं बन रही थी, margin axial reduction हो रही थी, उससे margin automatically बन रहा था. You can see the anatomy being followed. Interproximally अभी तक नहीं गए हम. You can see the anatomical form. Now you have enough space for the lab to fabricate a crown. Along with that, you have enough space to form the contours as well. Cervical to mid and mid to incisal. This I would take few seconds here and for you to know and judge. अगर किसी का internet मेरे से pace पर नहीं है या मेरा slow है, whatever. This is what anatomical form means. Convex surface को follow करना. बहुत आसान है बर को रख के इसको straight prepare करना. As you can see the image here. Excuse me. बहुत आसान है. But what you'll do, आप बिल्कुल पल्प तक चले जाएंगे, anatomy भी lose कर जाएंगे. So this is called planar reduction. That's how you do just by holding the angulation. ये achievable है. I'll show you in the video as well. You can see the contours. अब इतना space है, जब यहाँ canine आएगा तो वो बाकी दांतों की aesthetic से match कर जाएगा. And by doing that, you tend to remove the undercuts as well. Sometimes ये belly बाहर आ जाती है, but वो slight reduction से हो जाता है. Because undercut present hota hai, usko angulation, this is how you hold the handpiece in cervical angle, marginal area, and then change the angle to remove the undercut. This is how planar reduction you do. Central incisor ho, lateral ho, canine. Ye, even premolars, those are also reduced in planes. Even molars, jo अच्छे bulbous molars होते हैं. As Rosenstiel tells us, you have to follow the anatomy. अगर मैं ये red line को follow कर रहा हूँ, I've seen the image here. I'm maintaining the integrity of the tooth structure. I'm not going unnecessarily inside the pulp. अगर मैं straight रख के prepare करूँगा, what I'll do is I'll flatten the tooth, I'll lose the retention, I'll lose the tooth structure, I'll eventually lead up to the root canal. Then we move on to the interproximal reduction. Always remember, you're reducing the tooth, you're reducing, उसकी prep कर रहे हैं. Do not go inside the tooth you're not preparing. Slightest or touch to the adjacent teeth would eventually cause caries there. So maybe you need to reduce more interproximally. You need to do that. ये तो reduce हो रहा है, इसकी interproximally reduction हो जाए, दूसरों पे नहीं effect आए. So you take the thinnest burr and keep on ऊपर नीचे movement करते हुए, ऐसी movement करते हुए जाएंगे. Yes, you can keep a matrix band as well. I've never kept it. शायद सुस्त हूँ और पतले बर अवेलेबल. पतले बर थोड़े महंगे भी होते हैं, याद रखिएगा. बट मैट्रिक्स बैंड रख लें एंड देन कीप ऑन मूविंग. वो वीडियो में भी दिखाऊंगा. ये जो अनसपोर्टेड स्ट्रक्चर रह जाएगा, ये इवेंचुअली फ्रैक्चर हो जाएगा. एंड यू नीड टू क्रिएट इनफ स्पेस फॉर योर नेक्स्ट थिकर बर टू गो इन. इतनी स्पेस कम ना हो कि साथ वाले दांत पे लग जाए. एज यू कैन सी इन क्लोजली इस तरह होगा. साथ वाले दांतों से ये तो पहले से भी कॉन्टैक्ट टाइट नहीं थे, लेकिन स्लाइटली टाइटर थे. अब इस पे जब आप शैम्फर ये शोल्डर पर चलाएंगे, ये खुद ही मार्जिन प्रिप हो जाएगी इंटरप्रॉक्सिमली. आर यू गेटिंग माय पॉइंट? एनी क्वेश्चंस? क्वेश्चन एंड में लेने का बोला है. दिस इज अ रफ इनिशियल प्रेप. फिर आप लिंगुअली आएंगे, लिंगुअली भी प्रिपेयर करेंगे. This is how the lingual prep is done. Below the cingulum and above the cingulum is with a flame shape. Try to move your burr in one direction. No back and forth movement. Slight smooth movement honi chahiye. Fulcrum leke and हवा में हाथ नहीं होना चाहिए. Prep हवा में हाथ की वजह से खराब होती है. Prep irregular burr या movement of the cartridge की वजह से खराब होती है. तो steady hands के लिए and magnification जरूरी है. Without magnification, whoever's working, वो I would, with all due respect, precision का काम नहीं हो सकता उससे. Precision के लिए you need magnification, and to increase the number of years of dentistry, आपकी neck और ये posture improve करने के लिए magnification is mandatory. That is how you critically appraise your preparation. Critically evaluate, not praise, but critically evaluate your preparation. So you can see the margin being formed lingually. I'll show you the occlusal view. ये margin बन रही है lingually. As you can see, the margin is similar to the one made on the buccal side or the labial side. Cingulum preparation is done carefully कि नीचे का दांत आके उधर अगर cingulum पे लग रहा है तो you use the flame shaped rugby burr. Narrow मैंने डेमो में थोड़ा thicker burr use किया है, लेकिन वही उस वक्त available था. But As you can see over here, slightly the narrower burr is being used, and this is the area. ये concavity को further concave करना होता है, बहुत over reduce नहीं करना. जैसे ही patient की clearance आ जाए, this is enough. By virtue of doing this, आप क्या कर रहे हैं? Lingual भी anatomical reduction हो रही है. अगर straight करेंगे, cone shaped हो जाएगा. Canine बहुत जल्दी cone shape हो जाते हैं, पता ही नहीं लगता, बिल्कुल यूं cone बन गया. If you're following the lingual anatomy as well, I'm maintaining the contours. लैब के पास भी contour सिंगुलम का बनाने की जगह होगी, क्योंकि अगर आप फ्लैट कर देंगे, लैब उसको थिक करेगा, पोर्सिन फ्रैक्चर चांसेस बढ़ जाएंगे. Then we start blaming our laboratory technicians. So this is how after the lingual preparation, what do you call it, the flame shaped bar, this above the cingulum is prepared, below the cingulum the marginal area is prepared. Then you extend into the proximal area, और इसको सारे एक प्रेप को राउंड ऑफ करते हैं. As you can see, the mesial slope, distal slope, mesial slope, distal slope, and height, less taper, and rounded cavo surface angle. And eventually finishing the preparation, rounding off all line angles. And this is how the final preparation should look like. So any question you can write down and we can ask in the end, we can discuss in the end. So this is the entire assembly of instruments which are going to bombard your tooth while doing the preparation. राउंड बर किसी को और prominent margin चाहिए होती है तो राउंड बर भी यूज हो सकता है, बड़ा beneficial होता है, but with care obviously. Commence on the crown prep. By now you'll be able to, after whatever we discuss, who's been following me from slide 1 till here, they should be able to comment on this prep now. No margin, over tapered, less occlusal gingival height, no anatomical contours. So now we move on to the clinical side. Stepwise मैं आपको clinical step जो अभी दिखाए हैं वही आपको clinical video में दिखाऊंगा. So we start with the incisal reduction. Depth orientation grooves. And then joining the groove, as I mentioned earlier. Avoid reducing the groove area, but you can always reduce the islands next to the grooves. उससे फिर आपका slope भी बनता है. Yes, this was the incisal reduction. We move on to the second step, is labial reduction. You can also zoom in the screen ताकि आपको closely भी नजर आए, because I saw that on the screen, तो वो भी आप कर सकते हैं. Yes, मैं इधर से पॉज करूंगा और मैं वापस शुरू में जाता हूँ. आप पूछ सकते हैं कि आपने मार्क क्यों किया. मार्किंग देखें, ये टू एम्फसाइज, नॉर्मली हम दांत पे नहीं करते, बट टू एम्फसाइज आप कर भी सकते हैं, गुनाह नहीं है. टू एम्फसाइज के मैं पहले सर्वाइकल कर रहा हूँ एंड देन इंसाइजो मिड पार्ट कर रहा हूँ, ठीक है ना. 2 प्लेन्स में रिडक्स कर रहा हूँ. एज यू कैन सी, मार्किंग का पहले सर्वाइकल पार्ट हटेगा, फिर नेक्स्ट पार्ट हटेगा. अगर मैं बिल्कुल स्ट्रेट रख के कर रहा होता तो बिल्कुल सारा मार्किंग हट जाती. सो दिस इज फॉर डेमो पर्पस टू शो यू. तो इंसाइजर रिडक्शन इज डन. ये सारी जो पहले क्लिनिकल दिखा चुका हूँ पिक्चर, उसी का क्लिनिकल डेमो है. Another important point to note is bird is moving in one direction. आगे पीछे घिसना नहीं है, एक तरफ से ले जाएं, stop one, then come back, stop, मतलब, and a lot of water, the copious amount, the amount of water more, it will cool your tooth. Debris accumulation on your burr भी कम होगा. Debris जितनी accumulate होगी डेंटिन की, वो burr को useless करती जाएगी, वो clog हो जाएगा. So what am I doing right now? I'm taking the Explorer, the probe, and then moving it around the margin कि smooth margin है या नहीं है. इसी स्टेप पे आप देख लेते हैं कि स्मूथ मार्जिन अचीव हो रही है नहीं हो रही, और इसी स्टेप पे आप स्मूथ मार्जिन को ही फॉर्म करते हैं. आई एम डूइंग द एक्सियल रिडक्शन, द सर्वाइकल रिडक्शन, मार्जिन मेरी ऑटोमेटिक बनेगी. आई वाजंट ट्राइंग टू मेक अ मार्जिन, यस आई वाज ट्राइंग टू आउटलाइन द मार्जिन, और उसी आउटलाइन को बार बार फॉलो करूंगा, मेरी मार्जिन बड़ी से बड़ी होती जाएगी जितनी मुझे रिडक्शन चाहिए. And please note, the cervical area has been prepared, but the mid to incisal area is yet to be prepared. And then I move on to the second part of the labial reduction. If someone raised their hand, you need to ask some question or what? I don't know.
The question is, why is the burr straight here?
Yes, I'll just go back. Thank you for asking. ये अच्छा हुआ आपने जरा पूछ लिया. इसको मैं जरा Okay, I go back. ये मैंने पिछली स्लाइड पे दिखाया था कि पहले मैंने इसका सर्वाइकल प्रेप किया था. If I go back a slide. Yes. So labial reduction is done in two planes, जो मैंने आपको पहले mention किया था. First is cervical plane and then is the mid incisal plane. तो ये पहले cervical prep हुआ, जो इसको आप जल्दी से देख लें. ये cervical हो रहा है, और फिर आज जब mid part करेंगे तो वो आपको straight लग रहा है, लेकिन वो उसी के angle को follow कर रहा है. ठीक है ना, ये आपने देख लिया. Move on to the next part. Yes, it looks straight, लेकिन ये angle पे ही है. उसी तरह contour भी दिखाऊंगा आपको. ये एंगल ही फॉलो कर रहा है, बिल्कुल 90 डिग्री नहीं है. She's raised her hand again. Yeah. So if you can ask the question. And the contour is followed. Someone raised their hand. So if the moderator can see what they're saying, please.
Sir, it is beneficial to use end cutting margin refinement burrs.
Yes, in the end, you can use those. So because once the prep is done, you don't need to, and you're fine with the reduction. आप उसको end cutting burr से सिर्फ finishing भी कर सकते हैं. So it's always beneficial. ठीक है, और कुछ भी पूछ सकते हैं. So we move on to this next step. Is interproximal, the most critical. Do not go inside the tooth you're preparing. अब इसमें आप zoom करके देख लीजिए. Go inside the tooth you're preparing, even if you need to reduce more.
Sir, for incisal and labial reduction, which but did you use?
अभी बताता हूँ आपको. ये देख लें interproximal. I'm just making sure कि वो thin shell of enamel है जो कि adjacent दांत को, आप लोग zoom करके देख लीजिएगा अपनी screen पे. And देखें अब फौरन ही, as soon as my burr went in, वो unsupported enamel chip off हो गया था. वो chip off हो गया था. और डिस्टली भी ऐसे ही कर रहे हैं. अच्छा, the burr was, sorry, the सवाल was, क्या था सवाल? और
For incisal and labial reduction, which burr did you use?
incisal में short taper and labial reduction TR13C, ये दो बार यूज किए थे. ठीक है. और भी साथ साथ मैंने यूज एंड कटिंग burr margin in shoulder chamfer, the knife edge margin. शोल्डर शैम्फर नाइफ एज तो रेकमेंडेड नहीं है ये। चले एंड में मॉडरेटर साहब, आप डॉक्टर रिजवान आप हेल्प कर लीजिएगा सवालों का, तो दे देंगे एक साथ। So enough space for the next bar or the TR13s to go in. ये मेरे लूप्स की लाइट ऊपर नीचे हो रही थी, तो आई वाज सॉरी। वेब सिर्फ बता रहा था कि इनफ स्पेस क्रिएट करनी है इंटरप्रोक्सिमली कि थिन शेल। आई वुड रिपीट दिस वीडियो अगेन कि थिन शेल देखिएगा मीजली कैसे उड़ता है। So that is what is required. You go inside the tooth. जैसे ही आप up and down डालेंगे वो thin shell एकदम से हटेगा, तो that is preventing the adjacent teeth from damage. Please see this carefully.
So can we use safe-ended burrs for proximal clearance?
बताता हूँ। Please see this carefully. मैं इसीलिए ये चला रहा हूँ आपको। देखा आपने कैसे वो टूटा। So move on to the next step. And then this is the TR13C. So ये सर्वाइकल जो इधर से चल रहा था, अब उसी को आप कंटिन्यू करेंगे इंटरप्रोक्सिमली, तभी एक लेवल की मार्जिन होगी। ऑल्दो इंटरप्रोक्सिमली यू फॉलो द जिंजिवल एरिया, बिल्कुल स्ट्रेट अंदर नहीं ले जाते। सेफ हैंडेड बर्ड मैंने नहीं यूज किए इंटरप्रोक्सिमली, अगर आप कर सकते हैं तो कर लें। मैंने फ्रैंकली आई हैव ऑलवेज यूज्ड दिस ई डेंटा के बर्ड्स which I found nice to position and reduce interproximally. अब उसी मार्जिन को इंटरप्रोक्सिमल मार्जिन से मिला रहा हूँ। इसको रिपीट कर देता हूं ताकि एक दफा देख लीजिए। आई एम यूजिंग अ TR13C बर। सर्वाइकल जो मार्जिन बनी थी उसी को कंटिन्यू किया जा रहा है इनटू द इंटरप्रोक्सिमल एरिया। जूम इन, आपको एनाटॉमिकल कॉन्वेक्सिटी भी नजर आ रही होगी लेबियल सरफेस पे। Move on to the next step of lingual reduction. Proximally margin बन गई, लेबियल बन गई, अब lingual आप उसी तरह मार्जिन बनाएंगे जो कि आपको राउंडेड शो, एंड सेम TR13C बर यूज हो रहा है। Try to move in one direction. इरेगुलर जहां होता है उधर आगे पीछे करते हैं, वरना एक ही डायरेक्शन बना लें एंड कीप ऑन मूविंग इन दैट डायरेक्शन। ये अबव द सिंगुलम फ्लेम शेप बर से होगा, बिलो द सिंगुलम इधर TR13C से इधर हो रहा है। So you can see occlusally, if you see incisally, you can see a rounded margin all around जिसमें अंडरकट नहीं है। So this is above the cingulum, जो concavity है उसको फॉलो किया जा रहा है। इसमें इनफ क्लियरेंस हो जाती है तो आप ज्यादा रिड्यूस नहीं करना होता। You can see the margin all around, shoulder margin. और just finishing end में finishing of all the line angles incisal surfaces. Margin area को touch नहीं करें या non end cutting burr से कर दें अगर आपको करना है. Margin एक दफा बन गई, don't try to mess with the margin more, क्योंकि जब more you play around with the margin उतना खराब होती जाती है.
Sir, how much should we reduce in cingulum area?
1 mm is enough. Depending clearance कितनी चाहिए, 1 to 1.2 mm should be enough.
And what will be the direction of the burr, below the cingulum or above the cingulum?
Above the cingulum, जो आपकी cingulum के लव जो ऊपर जो concavity है ना, I'll repeat it again. तो मैं पीछे जाके आपको दिखाता हूँ cingulum वाला कहाँ गया. Yes, above the cingulum आप ये देख रहे हैं बर को, बिल्कुल बैक एंड फोर्थ स्मूथ करना है इसको, और कुछ भी नहीं करना. ये तो थोड़ा वाइडर बर आई यूज, लेकिन प्रीवियस इमेज में आपको थोड़ा नैरोअर दिखाया था. इसको ज्यादा प्रेस भी नहीं करना, बस उसी कॉन्केविटी को इतनी स्पेस बनानी है कि इंटरओक्लूजल क्लियरेंस आ जाए. ये आप देखें एक ही डायरेक्शन में मूव हो रहा है. And then, as I said, just finishing off all the rough areas or incisal tips if required. And then our preparation is done, as I mentioned earlier. पॉज करके आप देख सकते हैं ऑल अराउंड शोल्डर मार्जिन भी नजर आ रही है, क्लियरेंस भी है, देयर नो अंडरकट्स. So this was about canine preparation. Further reading के लिए, as I mentioned earlier, you can go back and study or check. But canine के अंदर उस books में इतना detail में नहीं दिया हुआ है. So I think this presentation will be available online as well. कुछ patient की तस्वीरें वो share मत कीजिएगा, बाकी तो खैर है. और I'm open to take any questions. I hope and pray my message was clear. Sorry about the initial lag. I had 3 internets available here, but lag हो जाता है कभी-कभी. This is Pakistani internet. Or any questions, please ask, or any suggestions. Also, I'm on the learning phase as well. I've stopped here with this slide just for you to remember कि anatomical shape कैसा होना चाहिए. जी, सवाल जवाब पूछ लीजिए अगर है
Okay,
कुछ.
sir, before the question answer session, I would like to invite Professor Dr. Uzma Zarif to please join us for vote of thanks, as without her support, this webinar series is not possible.
जी जी,
Over to you,
sure.
Dr. Uzma.
अस्सलाम वालेकुम. Can you hear me?
सलाम. जी
Yes.
जी
जी जी. अस्सलाम वालेकुम Dr. Samir and
जी,
everyone.
वालेकुम सलाम.
जी, thank you so much for a wonderful presentation. मैंने जहाँ
Thank
तक आपके हमेशा आपके एक्सपीरियंस से खुद बहुत सीखा है. And we are
thank
very
you.
thankful for Dr. Samir for taking out the valuable time, particularly on Sunday. I know this is the very busy day for everyone, and for taking out his valuable time today and being a part of the webinar of PDA Karachi. Thank you so much, sir. And I think our audience also have a great experience of learning today. And thank you so much for highlighting such clinical principles of crown preparation, particularly of the canine. And so we can, the outcome from this presentation, so we can give the cosmetic, aesthetic, and satisfactory crowns and prosthesis to our patients. एंड थैंक यू एवरीवन फॉर ज्वाइनिंग टुडे. और आप सबका भी बहुत बहुत शुक्रिया, क्योंकि संडे सबका ही बिजी होता है. और जो मैं देख रही थी माशाल्लाह, जो पार्टिसिपेंट्स की हमारी जो तादाद थी वो अल्हम्दुलिल्लाह इट्स क्वाइट गुड. एंड इसका ये दिस शोज दैट के एवरीवन ट्राई टू लर्न एंड ट्राई टू एंड वेरी डेडिकेटेड फॉर द लर्निंग. Thank you so much, Dr. Sameer, and thank you so
You're
much, Dr.
welcome.
Rizwan, and thank you for all the audience. Thank you.
Thank you, Dr. Uzma, and thank you for your team.
Thank
So
you
there
so
are certain
much.
questions. अच्छा,
Sir,
questions थे. अच्छा, Rizwan
जी
साहब,
जी जी
please
sir.
carry on.
Okay, sir, let's take some few questions. Number one, first question is, what steps can we take to reverse the loss of anatomical form of tooth prep?
हाँ, anatomical देखिए लॉस हो गया तो वो वापस तो नहीं आ सकता. As I mentioned earlier, all you can do is अब देखिए, why do you want an anatomical prep? ताकि लैब शेप अच्छा दे सके, वन. दूसरा, रिटेंशन रेजिस्टेंस के लिए. अब वो तो लॉस हो गया, तो फिर आप एडेड रिटेंशन फीचर्स देखेंगे, मे बी ऑक्सिलरी रिटेंटिव ग्रूव्स देखना चाहेंगे, उसमें देना चाहेंगे, बट डिपेंड्स ऑन द टूथ. अगर लोअर इंसाइजर पहले ही तबाह हो गया तो उसमें तो आप कुछ नहीं कर सकते. फिलिंग विलिंग करने से कोई फायदा नहीं है. तो प्लीज रिमेंबर, यस, सर्टेन केसेस में व्हेन द टूथ हैव्स स्ट्रक्चर लेफ्ट, यू कैन ऑलवेज, हम मैंने बहुत दांत, कभी होगा प्रेजेंटेशन में तो शो करूंगा कि बिल्कुल एनाटमी आउट थी, उसमें कैसे एनाटमी प्रोड्यूस की. दिस इज अ गुड टॉपिक टू डिस्कस. थैंक यू फॉर दिस क्वेश्चन. बट ऑक्सिलरी रिटेंटिव फीचर्स ही हम ढूंढते हैं कि क्राउन लेंथ बढ़ा दें या फिर ग्रूव्स दे दें अगर दांत में कहीं जगह हो देने की. जी.
Okay, sir, next question is, how much reduction in the singular place is recommended?
1 to 1.2 mm, अगर canine है तो 1.5 mm थे, लेकिन 1.2 mm is enough.
The next
अगर
question is,
जी
kindly
जी
explain in detail the chamfer and feather edge margins.
देखिए, chamfer margin, as shown in the presentation, I don't know if you can see, it's already on share. I'll go back. Feather edge तो बस ना हो तो अच्छा है. और जब ओवर टेपर्ड क्राउन होते हैं उसमें फेदर देते हैं. किसी ने वर्टी प्रेप का भी पूछा है, तो उसमें we'll discuss a bit about that. Going back to chamfer. Yes, is my screen? I'm sure the screen is visible. Uh, so I'll minimize this. So chamfer margin, yes, chamfer is a margin which forms an obtuse angle या sloping margin कहते हैं. ये theoretical है. ये normally veneers के लिए, ceramic veneers के लिए use होती है. और metal margin of the metal ceramic crown या all metal crown या gold crown के लिए भी use होती है. And it is more conservative as compared to your shoulder margin. तो जहाँ पे कोई ऐसे दांत होते हैं वहाँ पे एस्थेटिक्स ज्यादा नहीं कंसर्न होती, तो वहाँ पे, और दांत का स्ट्रक्चर भी बचाना होता है, तो वहाँ पे हम शैम्फर प्रेफर करते हैं. कमिंग बैक टू, इफ आई गो फॉर ऑल सेरेमिक, उसमें फिर हमें डीप शैम्फर, जिसे राउंडेड शोल्डर कहते हैं, वो प्रेफर करना पड़ेगा. यू नीड मोर स्ट्रक्चर स्पेस. किसी ने पूछा था कुछ मटेरियल के बारे में, आई गेस डॉक्टर रिजवान उस पर आएंगे, तो विल डिस्कस दैट. So feather edge is just a slight margin with जो कि over tapered crowns, lower anteriors में भी use कर सकते हैं, but again उससे आपको ideal emergence तो मिलता नहीं है. तो next question please.
So what's your take on vertical preparation? Which
जी,
cases you can
बट
go
डॉक्टर
for?
सोहेल ने पूछा है, बड़ा अच्छा सवाल. वर्टिकल प्रेप I would do when my lab is confident in doing that. I need to educate myself and my lab, number one. ये जो हम जितनी preparation कर रहे हैं, these are for all of you to understand. These are horizontal prep. इसमें दांत का structure. Verti prep is a minimal margin all around to structure, जहाँ से tooth का structure. This is a good concept. But again, I tried discussing it with my lab, so I wasn't confident कि मेरी lab इतना अच्छा margin area उसमें बना सकेगी. Overhang आ रहे थे. So we are into the learning phase lab, but I'm more confident in giving these more proponent of the horizontal क्या नाम है reduction than the verti prep still, because मेरी lab अभी इतनी acquainted नहीं है इससे. Requirement पे है, जितने ज्यादा लोग करने लगेंगे तो उतना बेहतर है. Yes, it's beneficial. It's reducing less. It's not destroying the tooth structure. So it's always there to opt for, but अभी तक तो नहीं किया है इतना practice इसके अंदर. Next question, please.
So next question is, what's the difference between zirconia and ceramic preparation? If you are preparing
अच्छा, मैंने
18
शुरू में मेंशन किया था, जो यहाँ सेरेमिक लिखा हुआ है, इट्स द लिथियम डाइसिलिकेट. लिथियम डाइसिलिकेट ये मटेरियल डिफरेंस है. Zirconium is basically a metal alloy, right? उसी का फॉर्म है. It's a color difference, but metal की तरह नहीं है, ग्रे या वो. And जो lithium डाइसिलिकेट है, it's highly aesthetic, हाईली सुपीरियर बट वेरी एक्सपेंसिव। लैब कम बनाती है क्योंकि उसकी जो साइकिल होती है बनने की, वेट साइकिल बहुत टाइम लेती है, तो इसीलिए मल्टीपल क्राउन्स के लिए रिक्वायरमेंट नहीं आती है उनकी। देन उसकी बॉन्डिंग होती है, तो स्टेप्स ऑफ सेमेंटेशन आर सेपरेट एज वेल। देन उसकी जो लिथियम डाइसिलिकेट है, अगर आप वीनियर दे रहे हैं और आपको हाईली एस्थेटिक चाहिए, गो फॉर लिथियम डाइसिलिकेट इफ योर लैब इज मेकिंग। बहुत कम लैब बनाती हैं क्योंकि उसकी रिक्वायरमेंट इतनी नहीं है, नंबर वन। Number two is lithium disilicate gives more lifelike appearance. Lithium disilicate is more technique sensitive in form of prep. सिरकोनिया में भी प्रेप अगर रफ हो चल जाए, लिथियम डाइसिलिकेट में टूटने का बहुत डर होता है। तो और यू नीड मल्टीपल स्टेप्स फॉर ल्यूटिंग दीज। इसको बॉन्ड करते हैं, साइलेन से ट्रीट करते हैं, एंड देन केमिकल एडिशन करते हैं उसकी मटेरियल की विद सीमेंट। सो दैट वाज अबाउट लिथियम एंड जिरकोनियम। बहुत कॉमनली जिरकोनियम प्रैक्टिस हो रहा है, लेकिन जहाँ आइडियल हॉलीवुड स्माइल करेंगे तो वो लिथियम डाइसिलिकेट से आ रही है। ऑल्दो न्यूअर जिरकोनियम्स में अच्छी लेड जिरकोनिया आ गए हैं, बट इवन देन लिथियम डाइसिलिकेट इज वे अबव दैट। जी।
Sir, any difference in their depth parameters if you are preparing anterior teeth?
नो, इट्स मोर और लेस द सेम। आप उसमें भी 1.2 to 1.5 रिड्यूस करते हैं, इंसाइजली 2 mm तक मैक्सिमम जाते हैं, लेबली 1.2 to 1.5 ये रेंज है डिपेंडिंग ऑन द टूथ। लोअर इंसाइजर है तो मैं 1.5 नहीं जाऊंगा, अपर सेंट्रल और अपर केनाइन है तो उसमें ज्यादा रिड्यूस कर लूंगा। तो ये रेंज इज फ्रॉम 1.2 to 1.5 लेबली, लिंगुअली, एंड मार्जिन अगेन रेंज इज फ्रॉम 1.2 to 1.5 रखें। ये 1 mm जो मेंशन था थोड़ा कम था अकॉर्डिंग टू माई बुक्स। जी।
Sir, Emax and lithium disilicate are same things?
सेम सेम सेम। ईमैक्स तो कंपनी जो उसको बनाती है ना, वन ऑफ द कंपनीज है। जी।
There is a
ये
repeated
फ्लेक्चुरल,
question.
सॉरी, फ्लेक्चुरल स्ट्रेंथ अगर दोनों की कंपेयर करनी है, राउंड अबाउट मेरे नॉट ऑन टॉप ऑफ माई माइंड, बट इसका क्या नाम है, लिथियम डाइसिलिकेट का 360 to 400 कुछ जाता है एमपीए, एंड उसका जिरकोनिया का तकरीबन आपका 950,000 तक जाता है, क्लोज टू मेटल एलॉयज। तो स्ट्रेंथ वाइज भी बड़ा फर्क है दोनों के अंदर। तो पोस्टीरियर पार्ट ऑफ द माउथ में ऑनलेस देती है दुनिया, हम कितना कॉमनली हमारी लैब प्रैक्टिस करती हैं बिकॉज हमारे पास इतनी रिक्वायरमेंट नहीं होती इसकी। तो लैब मैंने लगाए हैं ये लिथियम डाइसिलिकेट, बट लेसर अमाउंट, बट दे आर एक्सपेंसिव एज कम्पेयर टू जिरकोनिया, जिरकोनिया से भी महंगे हैं। चलिए नेक्स्ट।
Sir, I guess it's a repeated question. How to create a deep chamfer margin?
अच्छा, डीप शैम्फर में TR13C के ही आप डेप्थ को इंक्रीज कर दें तो डीप के वो सरफेस एंगल बन जाता है, जैसे इस प्रेजेंटेशन में आपको मैंने दिखाया भी, वो डीप शैम्फर ही बन रहा था, फ्लैट बट जॉइंट नहीं बन रहा था, डीपर शैम्फर बन रहा था उसमें।
Sir, a question is, please elaborate about the stress distribution in ground prep or finite element analysis.
मतलब ये सवाल मैं नहीं समझा, ये तो बहुत ही फाइनाइट एलिमेंट कहाँ लिखा हुआ है?
In the end, chat box, mein, please, from Dr. Arif Tahir.
और ये स्ट्रेस डिस्ट्रीब्यूशन इन ग्राउंड फ्लोर, लेकिन स्ट्रेस डिस्ट्रीब्यूशन फाइनाइट एलिमेंट एनालिसिस तो मेरे पास नहीं है इसमें, लेकिन स्ट्रेस डिस्ट्रीब्यूशन इज ऑल डिपेंडेंट ऑन द सीटिंग। For example, I'm seated on this chair and my one side of my chair is leaning to the right and the floor is uneven. तो वो load stress distribution even नहीं होगा। तो margin plays a critical role. As I showed you the images earlier, there were cracks, internal cracks happening, and that is why lithium disilicate especially, but zirconians also are not loving the irregular margins. आपका जो metal है, it's robust. Metal बर्दाश्त कर लेगा थोड़ी भी irregular margin हो, क्योंकि जब occlusal stresses आते हैं, सीटिंग के stresses आते हैं, forces are thrown along the long axis, then आपके internal cracks and stresses आते हैं, and that is where हम क्या करते हैं कि लैब को बोलते हैं यार तुमने ये जिरकोनिया बनाया था और इसमें क्रैक्स आ गए। क्रैक्स आर मोर टू डू विथ प्रेपरेशन एंड द ओक्लूसिव स्ट्रेसेस। ये समझना हमें जरूरी है, और ये मैंने शुरू में प्रेजेंटेशन में डिस्कस किया था थोड़ा बहुत। जी सर।
Sir, in RC treated tooth, is the same lingual reduction we do above the cingulum for like we do in vital tooth?
यस 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 यस, प्रिंसिपल देखें, रिमेन वाइटल नॉन वाइटल का डिफरेंट नहीं होते। नॉन वाइटल में ये होता है कि भाई फिलिंग किधर है, फॉर एग्जांपल प्रोक्सिमल फिलिंग है प्री मोलर में, मोलर में, अब मैं मार्जिन किस प्रोक्सिमल फिलिंग पे दूंगा? आई वुड अवॉइड गिविंग मार्जिन ऑन माय फिलिंग, I either go deep, yeah, I take select a filling which is does not shrink, which does not fracture. Oh, that is important. But the principles remain the same. इसी के साथ डॉक्टर आरेब ने पूछा specifically for canine guided occlusion. Always remember, if you're replacing restoration for canine teeth, you give shallow guidance. When I teach occlusion, when I discuss occlusion, that is my message. और ये पीटर डॉसन ने भी कहा है और स्टीवन डेविस ने भी कहा है, take your क्या नाम है canine out of guidance once you're give shallow guidance. आप भले उसको ग्रुप फंक्शन में कहते हैं, अब तो रिसर्च कहती है ये दोनों में जरूरी नहीं है कि भाई एक सही है दूसरा गलत है. It's what affects your TMJ. But canine में if I'm replacing a restoration, I give shallow guidance कि उस पे stresses ना आए. Canine is the most critical tooth in terms of क्या नाम है आपके जो lateral stresses हैं. Because अगर canine guided मैं उस पे दे रहा हूँ, chipping के fracturing के chances बढ़ जाते हैं. Thank you for a good question, Dr. Arif.
Okay, sir. So that's all question answer session. Thank you so much, Dr. Sameer, for your insightful session and your time, efforts, and
अच्छा, ये
contribution.
सवाल बड़ा अच्छा एक पूछ लिया मैं खत्म करने से पहले. What should be the best management sensitivity after crown prep? भाई इसमें तो गड़बड़ है ना. सेंसिटिविटी क्यों हो रही है? या तो ओवर प्रेप है, इसीलिए आई टेम्पराइज फर्स्ट. अगर वाइटल दांत है उसको ओवर द पीरियड टाइम छोड़ता हूँ, या ओपन मार्जिन है. ओपन मार्जिन का बेस्ट तरीका है बिफोर सीमेंटेशन आई टेक बाइट विंग्स, स्पेशली पेरिएपिकल नहीं तो बाइट विंग फॉर द इंटरप्रॉक्सिमल सीटिंग एंड बक्कल लिंगुअल पे आप ओपन मार्जिन देखते हैं. और सेंसिटिविटी हो रही है तो भाई कहीं गड़बड़ है तो फिर आपको इवेंचुअली डिसेंसिटाइजिंग एजेंट कर लें, बॉन्डिंग लगा लें, फिर इवेंचुअली एंडो पे जाना पड़ेगा अनफॉर्चुनेटली. जी
Sir, these are all question answers. Thank you so much, sir, for your time, efforts, for making
थैंक यू
this
जी. इट वाज
event
लवली टू
successful.
हैव यू ऑल एंड इट वाज लवली फॉर द डिस्कशन.
So, once again, thank you all for being with us. This is Dr. Rizwan Hassan, moderator of PDA-Karachi webinar series. We'll meet you again for the next webinar series with more educational sessions as they are lined up. So stay tuned and keep learning with us. Thank you so much, sir. And we are going to sign off until next time. Allah Hafiz and have a wonderful evening ahead. Thank you so
थैंक यू
much.
जी.